School, Al-Quds University, Al-Quds. Good morning. Welcome to Houston Methodist DeBakey Cardiology Grand Rounds. Dr. Stephen Little. Today it's my pleasure to introduce the speakers. We're going to continue our series of graduating cardiovascular fellows and their sort of final effort, the final boss, if you will, before they get to leave and graduate, is to give a grand rounds on a topic of their choosing. So we've been doing that throughout the year, and we are nearing the end of those presentations, saving some of the best for last. There are a couple of seats up front, if anybody wants to move up. All right, so a couple of announcements first. If you have questions, please use the microphones because this is being recorded, broadcasting to a worldwide audience on Venmo and YouTube. Recordings will be available for viewing perpetually, potentially. Go ahead and subscribe to our YouTube channel so you get the notifications. And if you'd like to submit questions, submit text DeBakey to the number 37607. A couple of other announcements. Pre-intern training for vascular residents will occur on June 16th. CV Fellows Boot Camp on August the 8th, and multimodality imaging for clinicians in the fall on October the 8th. Okay, so without further ado, it's my pleasure to introduce our first speaker. Dr. Mohamad Taha is one of our two Chief Cardiology Fellows at Houston Methodist. He earned his medical degree with honors from Al-Quds University in Jerusalem and completed his internal medicine residency at Wayne State University, and he's currently pursuing a master's degree in public health at the University of Florida. Dr. Taha's clinical interests include interventional cardiology and structural heart disease. He's also passionate about improving cardiac outcomes in cardiometabolic disease and advancing the quality of cardiovascular care through implementation science. And he's chosen a really interesting topic, which is BMI and cardiovascular outcomes in the current era and revisiting the obesity paradox. So without further ado, Dr. Taha, come and entertain us and educate us.
All right, thank you, Dr. Little, for the introduction, and thanks for the opportunity to present today. Well, good morning, everyone, and thanks for being here for Ground Rounds. My name is Mohamad Taha. I'm the third-year cardiology fellow at the Houston Methodist, and I am interested in presenting to you a topic titled BMI and cardiovascular outcomes in the current era, revisiting the obesity paradox. Those are some of my learning objectives for today, including highlighting the epidemiological burden and trends of obesity, examine the impact of obesity and cardiovascular outcomes, define the concept of the obesity paradox and discuss some of its limitations, and highlighting the role of emerging medical and surgical obesity therapies on cardiovascular outcomes. First, I want to highlight the challenge of obesity prevalence throughout the country. This is the most recent heat map data from the CDC showing the regional trends of obesity across the US. Currently, there are 24 states in which 35% of adults have BMI more than 30, which is obesity. And the highest prevalence of obesity are within the Midwest and South parts of the country. What about future trends? It is expected in 5 years, by the year 2030, that 1 in 2 adults in the US to have BMI more than 30, which is obesity class 1 by definition, and 1 in 4 to have BMI more than 35, which is obesity class 2 by definition. So starting with takeaway message number 1, obesity trends are alarming, and it's a true national epidemic, and we as cardiologists are at the front line facing it. Now shifting gear and talking about the impact of obesity on outcomes. In this large-scale meta-analysis of more than 240 prospective studies, including more than 11 million participants with a mean follow-up of more than 11 years, results showed that for every 5 BMI units above the normal weight range, there is an associated 30 to 50% increase in risk of overall mortality. And the mortality risk is more prominent in men and younger individuals compared to women and older individuals. As regards to cardiovascular mortality, another large-scale meta-analysis of more than 10 million individuals showed that for every 5-unit increase in BMI, there's an associated 42% increased risk of coronary heart disease. Similar to coronary heart disease, there was also a 42% increased risk of stroke with every 5-unit BMI increase, and this is quite significant clinically. The cardiovascular risk associated with obesity extend to pretty much all the spectrum of cardiovascular disease that we see and treat on a daily basis, including heart failure, calcific aortic stenosis, and atrial fibrillation. And there are many, many more examples. It's hard to summarize in one slide or presentation. So takeaway message number 2, the obesity is associated with significant cardiovascular morbidity and mortality, involving the whole spectrum of cardiovascular disease. Moving on to the obesity paradox, it's one of the concepts that I found very interesting in this field, which is a very counterintuitive observation that while obesity is an established risk factor for cardiovascular disease and lead to cardiovascular morbidity and mortality, individuals with overweight or obesity often experience better short-term or intermediate-term outcomes compared to individuals with normal weight. Let's take the heart failure as an example to illustrate this concept. We all know that increased BMI is associated with increased risk of heart failure through multiple mechanisms, such as diabetes, hypertension, and endothelial dysfunction, and inflammation, and so forth. And this figure shows that more obesity, more risk of incident heart failure. However, once heart failure diagnosis is made, it seems that survival among patients with overweight or obesity is better compared to heart failure patients with normal weight. The obesity paradox observation is not limited to heart failure only. It actually extends to almost all cardiovascular disease that we see and treat. Another important example is the ASCVD and coronary artery disease population. In this population-based study, more than 200,000 patients with ASCVD, we noted that overweight and obesity are associated with significantly less risk of all-cause and cardiovascular mortality compared to individuals with normal BMI range. Similar to that, the results extend to the post-PCI group, the post-CABG group. They have better outcomes in the overweight or obesity class 1 at least compared to normal weight. Post-TAVR again, patients with atrial fibrillation. So whatever there's a cardiovascular disease you can think of, the paradox applies to it when we use BMI to define obesity. So there are a few questions that need to be answered based on this, what I have shown so far. Question number 1, is BMI adequate predictor of cardiovascular outcome or not? Number 2, what alternative measures of obesity are available to assess cardiovascular risk? And another question is, what is the role of weight loss, if any, in patients with obesity and cardiovascular disease? Let's consider this real-life example. Arnold, when he starred in the movie Terminator 3, his BMI was 32. The BMI alone at that time can tell us one thing, that he's in the range of obesity class 1. However, this BMI fails to tell us about his body's composition or content of fat, lean versus fat mass, or fat mass distribution. But luckily, we have multiple measures that can potentially overcome the BMI limitation, and I'll mention a few of them. Waist circumflex and waist to height ratio are probably among the most informative obesity measures we have out there. They are more likely to inform us about the fat distribution than any other measure, especially the BMI measure. In this large-scale meta-analysis of more than 15,000 patients with coronary artery disease, measures of central obesity like weight, waist-to-height ratio, or waist circumflex were directly associated with higher mortality in patients with CAD, whereas the opposite was observed based on BMI classification. These data suggest that waist circumflex and waist-to-height ratio can be more reliable than BMI in stratifying mortality risk in patients with CAD. What other measures we have? fat mass is another important measure of obesity and adiposity, and that could be a better tool to assess risk for patients who have cardiovascular disease. Another large-scale data of more than 35 studies and 1 million participants with CAD, higher body fat content was related to higher risk of mortality as opposed to BMI. Beyond total fat mass, there is a strong evidence supporting that regional distribution of body fat is very important in informing us about cardiovascular risk. This includes hepatic mass, epicardial or pericardial fat mass, and muscle fat mass. Let's take an example of pericardial or epicardial fat mass. In this study that includes 4,000 patients with coronary artery disease, the pericardial mass that was assessed using either CT or MRI was superior to BMI in predicting MACE in this patient population. So takeaway message number 3, alternative measures of obesity, such as central obesity and fat mass, could be used to better assess cardiovascular risk and challenge the concept of the obesity paradox. Moving on to a little bit more clinically relevant questions, is there an actual benefit of weight loss or not? And if so, what is the goal of weight loss? Yes, of course, there is benefit for weight loss. And many studies have shown that weight loss is beneficial for a wide range of cardiovascular risk factors. These percentages changes, but the magic number seems to be 10% to gain net cardiovascular risk factor benefit. What about improving cardiovascular outcome? One of the large prospective trial, the Look-Ahead trial, looked at weight reduction and cardiovascular risk benefit in patients who have type 2 diabetes. With a weight loss of 8.6% at 1 year, there was no reduction in cardiovascular mortality or MACE at 10 years. However, in a subgroup analysis, those who lost 10% or more body weight, they saw a 20% reduction in cardiovascular mortality or MACE. This figure here shows that what's available out there in terms of medical and surgical therapy for obesity until recently. Medications at that time were unlikely to get people to lose 10% or more of their body weight. And surgical management of obesity were the only options that can lead to a significant weight loss that can derive actual net benefit. But now, we have a powerful tool that can be utilized. The new class of medications, the GLP or GIP-1 receptor agonists, are quite powerful, and weight loss associated with their use is close to a bariatric surgery range of weight loss. These medications has been there since 2006. A few of the FDA-approved agents for weight loss, including liraglutide, semaglutide, and tirzepatide. The mechanism of action is quite complex. Some of it is understood, and some of it is not fully understood. But most commonly, they work on the brain, gut, and pancreas axis through different mechanisms. Let's look at one of the most remarkable trials, including the STEP 1 trial. That was the first trial to ever show that semaglutide was associated with significant reduction in body weight. 2,000 individuals with BMI more than 30 and without type 2 diabetes were enrolled in this trial. And by the end of the study period, the average weight loss was 16% in the treatment group as opposed to 5.7% in the placebo group. And if we truly consider 10% is a meaningful clinical reduction in body weight, then 75% in the treatment group achieved weight loss of 10% or more. And one in three achieved 20% or more weight loss in the treatment group. Then came tirzepatide in the Surmount-1 trial that showed us that even more weight loss is even possible. 2,500 individuals with BMI more than 30 were enrolled in this trial. And by the end of the trial period, the average weight loss was 23% compared to 2% in the placebo group. 90% of the individuals achieved 10% or more weight loss, and 40% achieved 25% or more weight loss. One of the concepts that I want to touch base on in this trial, 1 year after withdrawal of subcutaneous semaglutide in the STEP 1 trial, participants regained 2/3 of their prior weight loss So it's very important that findings of this study confirms that the chronicity of obesity and suggests ongoing treatment is still required to treat the impact for weight loss and for health impact. So takeaway message number 4, GLP and GIP-1 receptor agonists are associated with robust reduction in weight loss as high as 23%, with weight gain expected with medication withdrawal. Now, moving on about the cardiovascular outcome associated with these medications. The SELECT trial is probably one of the most paradigm shift trials in the last few years. It was a mega trial. They included 17,000 patients who have BMI more than 27 and who do have underlying cardiovascular disease, whether it's prior MI, stroke, or PAD. They randomized patients or individuals into the placebo or the semaglutide group. Here, I want to highlight that the semaglutide group, the dosage was the same dosage used in the weight loss trial. And the primary endpoint was a composite of CV death, non-fatal MI, or non-fatal stroke. The treatment group was associated with 20% risk reduction in the composite endpoint. So the SELECT trial was the first ever trial to demonstrate cardiovascular benefit of a GLP-1 receptor agonist in patients with obesity, without type 2 diabetes, and established cardiovascular disease. But we have to be careful about making conclusions about the mechanisms of action of these medications, because this trial was actually designed not for weight loss, but actually for a cardiovascular outcome trial. So although it used a medication that is lead to significant weight reduction, we don't know exactly if that is truly the mechanism. The cardiovascular outcomes extended beyond the ASCVD population. In 500 patients with HFpEF and BMI more than 30, semaglutide was associated with improved quality of life and significant weight loss compared to the placebo group. Looking at the tirzepatide outcome trials, a treatment with it led to lower risk of composite cardiovascular mortality and or heart failure hospitalization in more than 700 individuals with BMI more than 30 and underlying HFpEF. Is there any data to look at tirzepatide outcome related to coronary disease or atherosclerotic cardiovascular disease? There's a trial in progress. It's the Surmont MMO trial that will have very similar design to the SELECT trial, similar population size, and they're going to be look at a composite of cardiovascular outcomes. Now, how does these medications reduce cardiovascular outcomes? I think it's a very difficult question, and I don't think there's data to suggest one single mechanism, but rather a combination of different pathways. We have metabolic factors such as weight loss, control of some of the lipids, and glycemic control, as well as reduce in insulin level, which is very important in the pathophysiology of obesity and cardiovascular disease. We have vascular factors, including blood pressure control and enhanced endothelial function. We have antithrombotic factors that include stabilization of vulnerable plaque. And we have anti-inflammatory factors. And we saw in some of the trial reduction in the percentage of CRP, TNF-alpha, and interleukin-1 that could be correlated with cardiovascular disease in obesity. Taking example of one of the recent trial of tirzepatide and how it can have a significant impact on the cardiometabolic health, we saw a 10-point reduction in systolic blood pressure with tirzepatide, 5-point reduction in diastolic blood pressure, better glycemic control, significant reduction in fasting insulin level, which insulin resistant is one of the hallmark of obesity and cardiovascular disease, significant drop in triglyceride, waist complex, and a 40% reduction in high sensitivity CRP. Now, if there is a medication that can reduce weight similar to bariatric surgery, then does bariatric surgery is associated with better cardiovascular outcomes or not? The answer is most likely yes, based on multiple high-quality observational data. They looked at, there's multiple cohorts, they look into composite endpoint of different groups, And the risk reduction associated with bariatric surgery was up to 50% in the post-operative period. But do we have an actual high quality randomized trial showing better cardiovascular outcomes after bariatric surgery? The answer is not yet, but we are looking forward to the results of the BRAVE trial that will randomize patients with BMI more than 35 and established cardiovascular disease into medical management arm versus bariatric surgery arm. And the endpoint will be the composite of all-cause death, MI, stroke, or heart failure hospitalization. So key points, takeaway number 5 is GLP-1, GIP-1 are associated with improved cardiovascular outcomes in patients with established cardiovascular disease, mainly in the ASCVD population and the HFpEF population. So key points from this presentation is obesity is a true epidemic. Obesity is strongly associated with cardiovascular morbidity and mortality. BMI is not enough to define obesity, and other measures are needed, such as fat mass, waist circumference, or waist to height ratio. And GLP-1 or GIP-1 receptor agonists are associated with robust weight loss and improved cardiovascular outcomes in patients with established cardiovascular disease. Last but not least, I would like just to thank Dr. Malhavji, Avanati, Patel, and Nasser for helping and guiding me in this presentation. And happy to answer some questions.
Okay, thank you, Mohamad. That was excellent. Nice overview of a fairly complicated topic. We'll pass the mic out in a sec. Just one quick question for you. You started with, defining, I guess, the obesity paradox, and at first my question was, is that paradox related to the imprecision of the definition of obesity? Is that part of it, or is there, and I guess, how much of an issue is the definition of obesity in that paradox?
Yes. Very likely it's related to definition because definition was based on BMI classification, and BMI does not actually tell us about how much fat mass we have, and the fat mass changes over time and changes with age. There's a lot of biases in the large trials or observational studies that look at it. So part of it related to the actual way we are defining obesity, part of it related to biases like survival bias in large studies, and part of it is we're not able to capture per category, like women, men, different age group, what is the fat mass distribution and what is the fat mass compared to the lean mass based on this sole BMI classification.
Very nice presentation and great work over the past few years, and for your chief residency also, chief fellowship. 2 questions. One, in follow-up to Dr. Little's thing. Yes, we can criticize BMI, but if we use any of the other measures of obesity, right, that you suggested,
yes,
do we no longer see it? Has anybody studied that? I know you may not have these measurements to be able to look at the previous studies showing, the effect of obesity per se.
Yeah.
So are there any signals to tell us that if we use any of these newer measures of obesity, that we no longer see the paradox?
Yes, we have very strong evidence, especially when we use measures of central obesity, such as the waist circumference or waist to height ratio. This is more likely to define the fat content and the fat distribution than BMI. And every time we look at these measures, the paradigm exactly the opposite compared to BMI. And part of the new guidelines is to start to define obesity by more than one measure, that is the BMI. We need other measures in addition to BMI to make that definition, whether it's like fat mass obtained by the different scan, whether it's by just obtaining a very simple waist circumference measure in the clinic.
And the second question is maybe extending the effect of weight reduction
Yes.
in patients who are obese. And in my mind, comparing conceivably a surgical approach to the GLP-1 agonist.
Yes.
The interesting data about the GLP-1 agonist is they're not only weight reduction and suppressor of appetite. They're
Correct.
anti-inflammatory, You can see effect on CNS, less
Right.
Parkinson disease, maybe dementia,
Yes.
so many other things. And the
Correct.
question is, since maybe the control is a surgical manipulation without any other systemic effect, do we see those signals in surgical attempt to decrease obesity as opposed to GLP-1? Is there any difference from a systemic effect?
Yes, correct. With weight loss surgeries, there's actually even more robust drop in blood pressure, and probably we can call it even cure from diabetes. After bariatric surgery, oftentimes patients leave the hospital in the post-operative period. If they were on insulin before, they will be completely off of it. As about to inflammation and endothelial function, I'm not quite sure about this, but I think there's a robust impact on the whole cardiometabolic with surgery as well. One important concept or difference between the two is that in recent times we have observed significant muscle mass loss with GLP-1 that we do not see necessarily with the bariatric surgery. How much of that has impact on the long term? Does that have a worsening outcome or not? I don't know the question. I don't think they have investigated that to date. But the studies showed that with GLP-1, patients can lose anywhere between 25 to 40% of their muscle mass. And this is quite significant. The theory is that the same way they lose their fat mass, they still lose other masses too. So it's proportional. But it still could be, has a future impact on overall wellness, functionality, or muscle weakness. And the last trial I showed that's going to be coming soon, they're actually going to randomize medical management versus obesity surgery for the first time ever. So we'll have more answers about mechanisms and impact.
But I assume that randomization will not include the new agents,
That, honestly, I don't know.
because then it would be a wash, you would expect.
So, Mohamad, wonderful presentation. Thanks for breaking down a complicated topic that's evolving rapidly. I know you've been involved in this space for several years now. So you started with the discussion about the obesity paradox and how individuals with higher weight may actually have prolonged survival compared with those with obesity. Dr. Little asked a little bit about that, but now I'm curious about what you take away as a clinical implication. Do you think that obesity should be a target for patients with established cardiovascular disease? And the second part of this question is, patients with established cardiovascular disease have multimorbidity, they're on several medications. Where do you think these types of agents that target weight loss are in terms of the priority of medications when you think about polypharmacy, cost, and what the patient has to experience?
Yes, excellent question. In terms of the paradox and obesity, because now we have very strong data suggest that weight loss have a 20% risk reduction in patients who have obesity and established cardiovascular disease. Treatment of obesity and established heart disease, I think, should be a priority. It's shown now, and I'm sure it's going to continue to be shown in the future trials because of their mortality impact and their whole cardiometabolic profile improvement as well. We saw a lot of inflammation reduction. We saw a lot of blood pressure control. So the whole impact, I think it's positive, regardless if we consider or not consider the obesity paradox in the back of our minds. The second question, if we're trying to prioritize medications, this medication is hypoglycemic medicine. It can be used in diabetes and not diabetes. It has a very strong evidence for mortality outcome, which is way more than any of the other drugs that we use or give the patients that do not have necessarily that much of cardiovascular outcomes. So I would rather prioritize medications that have true impact, including mortality outcomes, cardiometabolic profile enhancement, compared to medications we used to give them, but I'm not so sure about their mortality impact and the overall impact on the society when we have these improvement in cardiometabolic profile.
Okay, thank you, Dr. Taha. Well done. Okay, switching gears. Thank you, Mohamad. Switching gears, it's my pleasure to ask Yasseer Sammour to join us. Yasseer, glad you could make it this morning. Yasseer was born in the UK, did his training in Egypt, internal medicine in Kansas City. He's been with us for 3 years for internal medicine and is off to do interventional cardiology as his next step. Yasseer spends a lot of time and energy on research, and I think we're going to hear about some of that this morning. So over to you, Yasseer.
Right. Good morning, everyone. I'm Yasseer Sammour, one of the third-year cardiology fellows at UC Methodist, and it's my pleasure to present to you today this topic about health status assessment in patients undergoing transcatheter valve interventions, key insights and lessons learned. I have no disclosures other than I've been working with Dr. John Spertus for the last 6 years since my time in Kansas City. The key points for our study today, we're going to talk about understanding the importance of health status as an outcome, inclusion of health status in outcomes in clinical trials. Then we'll talk about health status benefits by valve and transcatheter intervention type, and then some controversies and future opportunities for improvement. So there is always some skepticism about the validity or importance of health status as an outcome. And sometimes they are viewed as being vulnerable to bias, complex, difficult to interpret. So I will try during this talk today to change your mind about the importance of health status and quality of life outcomes. So traditionally, there has been emphasis about hard clinical outcomes like mortality, bleeding, hospitalizations, especially in procedural or acute care setting. And clinicians are trained to focus on those outcomes. As a result, subjective outcomes like quality of life or symptom relief or functional capacity have been often considered secondary. But patients often come to us, whether in the clinics or in the hospitals, because they have complaints, they have symptoms, and they often seek us to help them with alleviating those symptoms. And some of them care about, or many of them actually care about feeling better as equally or even more than living longer. So what are the principal goals of any treatment? So we have two main goals. The first one is to improve clinical outcomes, control disease progression, improve mortality, hospitalizations, bleeding, and others, depending on the disease, and make patients feel better, improve their health status, alleviate their symptoms, increase functional status and quality of life. So we have some tools for assessment of health status. The first is generic, and it looks basically quantify the impact of the overall health on function and quality of life. We have the short form 36 and EQ5D. And we have some disease-specific health status measures which are more sensitive in quantifying benefits of treatment. The most popular one and most validated is the KCCQ, Kansas City Cardiomyopathy Questionnaire. Initially, it was a 23-item version, the original one, and then a shorter version came later with only 12 items. There is also the Minnesota Living Heart Failure Questionnaire for heart failure, Seattle Angina Questionnaire for coronary artery disease, and Peripheral Artery Questionnaire for peripheral artery disease. So what does the KCCQ actually measure? This is going to be the main focus of this talk because it has been like the most extensively validated measure for health status in patients with heart failure and valvular heart disease. So any disease in this situation, heart failure or valvular heart disease, it can cause symptoms which lead to functional limitations, reduced quality of life. The symptoms are assessed in the KCCQ by the symptom scale, all right? And there are also physical, emotional, social, physical and social subscales for functional limitation. And there is a quality of life subscale. So altogether, we have what we call the KCCQ overall summary score, which is what we usually report in clinical studies and clinical trials. So the clinical ranges of KCCQ score, it ranges from 0 to 100, 0 being the lowest and 100 being the highest. And usually we consider 0 to 24 as being very poor or poor, 25 to 49 as poor to fair, 50 to 74 fair to good, and 75 to 100 is good to excellent. And the changes in KCCQ, if it's 5 points, we consider that small but clinically meaningful according to some validation and studies. And 10 points is considered moderate to large, 20 points is considered large to very large. So how does the KCCQ, which is patient-reported, compare to NYHA, which is clinician-reported? In this analysis that compared the change in both measures in patients who were admitted for heart failure, there was a discordance between the change in KCCQ and NYHA from heart failure admission to 1 month of follow-up. As you can see here in KCCQ on the second panel, most patients had, or the majority of patients had, at least 10-point improvement after their heart failure admission, while in the case of NYHA, it was more of all over the place. So why is it important to use health status as an outcome in clinical trials? It is not a surrogate endpoint. It's not a surrogate for mortality or bleeding or hospitalization. It's just a direct measure for patient outcomes. It can be obtained in all survivors, unlike mortality, which is rare. So it gives us more power to detect significance between comparison arms. So now that we have a better idea about the importance of KCCQ as a health status outcome, I would like to take you through some results showing benefits by valve and intervention types, starting with the aortic valve, specifically in TAVR. So starting with the high-risk patients from PARTNER and the core valve high-risk trials. First, in PARTNER 1A, it included 628 patients, high risk with STS of around 11%. In those patients, health status improved substantially by about more than 20 points from baseline to 1 year. As if you can look at the 1 month data, in patients who underwent TAVR, there was early improvement with 23.7 points. But in patients who underwent surgery, there was a smaller improvement, about only 12 points, but then it catches up later at 6 months and 1 year of follow-up. Similar observation was seen in patients who underwent, high-risk patients who underwent TAVR or SAVR in the core valve high-risk trial. Still early improvement with TAVR, and then it becomes consistent, like very similar throughout 5 years of follow-up. And in this trial, they reported the rates of being having favorable health status outcome, which is defined as being alive with a KCCQ of 60 or more at 5 years. And 61 versus 65%, that's pretty good for this high-risk group. Moving to intermediate risk patients from the PARTNER 2A and SAPIEN 3 intermediate risk registry, there was still a significant improvement in KCCQ in patients who underwent TAVR at 30 days and 1 year. And we still see this delayed effect with the surgery, and that difference between the two groups improves later at 1 year. In the CERTAVI analysis at 5 years that was led by Dr. Kleiman, they also showed similar observations between TAVR and SAVR. And in this figure, they looked at whether there are any differences according to stratifying by the baseline STS risk score within the intermediate risk range. And the improvements in KCCQ were very similar throughout at 1 year and 5 years of follow-up. In low-risk patients from the PARTNER 3 trial, we still see some very similar observations in the KCCQ scores, and still difference at 30 days between TAVR and SAVR that becomes very similar later throughout 5 years. And patients who had excellent health status at 5 years were very similar between the TAVR and the surgery group at 71 versus 72%. And similar estimates were also seen in the EVOLUTE low-risk trial, and very similar also proportions of patients with excellent health status. What about the real-world patients outside the clinical trials? In the TVT registry analysis here, there was a larger increase in KCCQ, about 28 points at 1 month and 32 points at 1 year. And they also showed some factors that were independently associated with 1 year KCCQ. I would like to highlight the first one, which is the baseline KCCQ score. So here there seems to be like a positive relationship, but I would like to point out that if you start with a low baseline KCCQ score, you have more to gain from the intervention. So those patients should actually be the target for interventions. But overall, if you start with a higher baseline, you're bound to have a higher 1 year follow-up. So I mean, we need to know about those nuances when we look at the data, whether we look at the absolute value at 1 year versus the change from baseline to follow-up. And this is what this analysis did here from the TVT registry also. They looked at patients who were minimally symptomatic before undergoing TAVR, and they defined that as having a baseline KCCQ of 75 or more. Those were comprised 20% of the overall cohort in the TVT registry. And they had here in panel B, they had lower improvements in KCCQ. But despite that, they still had lower 30-day mortality, and they had higher likelihood of being alive and well at 1 year. Moving forward to the mitral valve. In this, in the COAPT trial analysis here, compared with medical therapy alone, undergoing mitral TEER was associated with early substantial improvements in KCCQ that were sustained at 2 years. The differences are not as robust as in TAVR, being like 16 points at 30 days and 13 points throughout 2 years of follow-up. And experiencing improved health status was significantly more frequent with mitral TEER at all points of follow-up. And if you look at the 2-year follow-up, it's almost double the amount of the proportion of patients, 40% versus 21% with the medical therapy alone. So are those benefits in KCCQ associated with clinical outcomes? This is what this analysis tried to address. And they found that patients who had moderate or large improvements in KCCQ of at least 10 points, they had lower likelihood of having death or heart failure hospitalizations throughout 2 years of follow-up. And after multivariable adjustment, the associations remained significant both in the composite outcome and in the individual endpoints of mortality or hospitalization. Similar findings were shown in the ReShape Heart Failure 2 trial, and the difference was 11 points between mitral TEER and medical therapy at 1 year. What about patients with primary MR? In this TVT registry analysis from 2018, the majority of the patients had primary MR, 89%. They had normal EF, but they still experienced significant improvements in their KCCQ and health status at 30 days and 1 year. And the majority of the patients, about over 70%, experienced improvements if we look at it that way. There are limited data about transcatheter mitral valve replacement, and we have only what I was able to find are only a couple studies from the TVT registry, one for patients with valve and ring, and one valve and valve, and one is in patients with valve and ring TMVR, and they both experienced very high improvements actually in KCCQ, about 30 to 40 points at 1 year of follow-up. Moving forward to the tricuspid valve with emerging transcatheter therapies. In the Triluminate pivotal trial, which randomized 350 patients with severe symptomatic TR to either tricuspid TEER versus medical therapy, the study met its primary endpoint with a win ratio of 1.5 in favor of tricuspid TEER that was mainly driven due to benefits and health status. And the proportion of patients who had at least 15-point improvement in KCCQ was 50% with TEER versus 26% in the control arm. At 2 years, the KCCQ improvements were sustained in the device group, and those patients who crossed over from medical therapy arm to the device arm showed also significant increases in their KCCQ. And I'd like to remind you that at 2 years in this study, recurrent heart failure hospitalizations were lower with the tricuspid TEER versus medical therapy. Similar observations were seen in the TRISCEND 2 pivotal trial with the transcatheter tricuspid valve replacement. Also met its primary endpoint with a win ratio of 2.0 in favor of TTVR. And the proportion of patients who had at least 10-point improvement was 66% versus 37% in the medical therapy arm. Both devices received FDA approval based on improvements in health status, despite not showing significant benefits in clinical outcomes like mortality or hospitalizations. And this is an important milestone for using KCCQ or health status outcomes as a primary endpoint for decision-making. So there is some criticism for using patient-reported outcomes in open-label trials and health status reporting. And some concerns are like the placebo effect, that patients can, like their belief in treatment effectiveness can change how they respond to these questionnaires. And the Hawthorne effect, like being observed or studied, can also change that. And there is also this phenomenon called regression toward the mean, that if you start with very extremes, whether too low or too high of KCCQ, you're more likely to regress toward the mean, even without doing anything. So we have to interpret this also with caution. And ideally, for device trials studying health status as a primary endpoint, it should be sham controlled. But does this mean that there is no value in doing open label trials if we can do a sham control? So I'd like to talk a little bit about the placebo effect and what is the magnitude for it. This study from 2001 combined data from 114 clinical trials, and they compared placebo versus no treatment at all. And there was no evidence for a clinical effect in the clinical endpoints, but in the subjective outcomes, such as pain reporting, there was about 0.25% standard deviation difference. And this is equivalent to only a 5-point change in KCCQ, not like what we see with 10 or 20-point improvement in the clinical trials with the transcatheter therapies. So deep dive into the TriLuminate pivotal trial to address those concerns. In the first figure here, you see that patients with severe or massive residual TR had less improvements in KCCQ versus those who had only moderate or less residual TR. And patients who had 1 or 2 grade reductions in TR severity, they had larger increases in their KCCQ at 1 year. This pattern with dose-graded response with the therapy is unlikely to be related to placebo effect alone. And then looking at the Transcend trial here, the time course of benefit is also atypical for placebo effect, with initial improvement at 1 month, and the difference becomes even larger at 6 or 12 months. This is what we see typically with effective therapies rather than just a placebo effect. And in this figure here also you see a dose-graded response that if you start with massive or torrential TR, you have more to gain in health status with bigger differences in KCCQ compared with the control arm. So I'd like to take a few minutes to talk about some miscellaneous topics about our work in this space. We looked at this analysis from the TVT registry comparing the effects of baseline tricuspid regurgitation on health status in patients undergoing TAVR or mitral TEER. And we found that having moderate or severe baseline TR prior to undergoing those interventions was associated with lower baseline and follow-up KCCQ and lower likelihood of achieving a favorable health status outcome at follow-up. We also looked at the impact of having coronary artery disease in patients undergoing TAVR. And we found that having either single vessel or multi-vessel CAD prior to undergoing TAVR was not associated with health status outcomes, which tells you that probably those patients, once you treat their aortic stenosis, it's likely what was contributing to most of their symptoms rather than the actual coronary artery disease. We have some work in progress about patient prosthesis mismatch after TAVR or SAVR from the partner trials we're going to present in New York Valves, and we also have some work about residual aortic regurgitations after TAVR and health status. So as we look forward toward the future of health status assessment, several opportunities stand out that could help us better harness its full potential in clinical care and research. First, improving the interpretability of health status scores like KCCQ remains a top priority. While these scores provide us with rich insights, they can be challenging for clinicians and patients to fully grasp, especially when trying to translate a numerical score into actionable care decisions. We have to improve data collection of health status, especially in large registries and clinical trials, to ensure reliability and generalizable findings. There is also an opportunity for using the digital transformation of data, using like tablets in waiting rooms or patient portals or even phone apps to collect KCCQ and make it more efficient and timely and with less burden for the staff. And integrating health status data into electronic medical records that are currently available could also facilitate real-time clinical decision-making and allow us to track longitudinal trends of health status, such as what we use for blood pressure checks or hemoglobin A1C. And finally, a significant motivator for widespread adoption could be reimbursement. If CMS or private payers begin reimbursing for health assessments similar to other quality metrics, that may incentivize routine use and signal to clinicians that these measures are not just research tools, but essential components of value-based care. I'd like to end with this slide. This quote is from 1990, from about 35 years ago. And they basically are saying the use of health-related quality of life measures, especially those based on function, is likely to increase during the next decade. However, it's more likely to occur in clinical research rather than clinical practice. And unless there is a necessary political will, resources, and policy researchers, there will be little advance in the use of health status measures for decision-making and policy-making. Fast forward to today, while we've made some strides, many of those barriers still remain. And this highlights how important it is to act on the opportunities we discussed earlier, rather than let them linger for another 35 years. In the end, I'd like to thank my mentors and everyone here at Houston Methodist. It's been a pleasure training here and learning from everyone. I'll be happy to take any questions.
Thank you, Yasseer. Very nice overview, complicated stuff. A couple of questions for you, or really one question to start off with. I really like that you highlighted the limitations of clinician-reported changes in NYHA class. Everybody's a 2 or a 3, so
Right.
It's such a coarse tool that it's basically useless when you see class changes. So that was great. And I forgot the second part of my own question. So I guess that's a compliment. So well done. It'll come back to me.
Thank you.
Any others? Who's got?
Hello. Thank you very much. It was like amazing presentation. I know this quality of life, it's so complicated. My question is like, as you point out, for at least when we are seeing the intervention arms, like change of KCCQ of 20, those are very significant. But it's very common for us to see like people reporting like change of 1 or 2 of KCCQ as a statistical significant and reaching to the conclusion that we have some quality of life improvement. So do you think it's time now, since every trial is including quality of life, to standardize the reporting that, oh, you can only report that if you have significant improvement in your conclusion part? Do you think this time has come for this scientific publications? It's like you have to mention this term. You cannot just use 5 or versus 4 as significant improvement.
I see your point. So it's a great point. Thank you for the comment. So I think you should still report what you have in the findings, but when you encounter a similar situation to what you're describing, you have to carefully interpret that, and it falls on maybe the researchers and also the peer reviewers to make sure that the assessment of those results are accurate. Consistently in the slides that I showed, like in the clinical trials, there were like 10 to 20 point or more improvements with the different therapies, and the improvements in actual registries like TVT was even larger. But I agree with you that sometimes if you have like a very large sample size and differences are like 2 or 3 points, it can still become significant, but we have to see what's actually clinically meaningful. And I would say like if you have like a small difference, like 5 points or more, it's still clinically meaningful and may warrant further exploration depending on the magnitude of the intervention you're providing.
Yes, sir, that was great, and congratulations on amazingly productive 3 years of research and clinical work. So you should be very proud of yourself.
Thank you so much.
And I like your association with Dr. Spertus, who I know very well and is an amazing contributor. Okay, I'm glad you picked this topic. Not too many people pick this topic, particularly with your knowledge in it. And I want to emphasize, or at least ask questions regarding this patient-reported outcomes, right? It's hard in the interventional world without a sham operation to be able to assess how much there is such an influence. So if you could tap on medical data, randomized data of placebo versus drug that have some influence on patient symptoms and outcomes, how is it influenced, particularly when you relate them to outcome? And I think the best probably example would be heart failure with medications, different medications. And also, I'm probably less bothered by the comparison of New York Heart Association to this, because they could complement each other. I think everybody knows New York Heart Failure Association number 4 is certainly different than 3 and 2, and there is some overlap in the others. But clinical data have shown for many years that it impacts outcome. So the question is the placebo effect, if you will, particularly in our field where most of the interventions, you really cannot do sham operation on them.
Yeah. So thank you, Dr. Zabi, for the kind words and for your comments. So starting with the sham operations, like I said, in a perfect world, any device trial that should be assessing health status as one of its main endpoints should be done as a sham-controlled trial. That's not always feasible, and depending also on the type of the intervention or surgery or whatever. But like we showed here in those slides, like there are some aspects that if you carefully interpret them, and like, for example, the magnitude of the change, difference between the two groups, if it's only like 4 or 5 points, that could be more likely to be related to the placebo effect or Hawthorne phenomena or regression toward the mean. But in those examples with either like mitral tear or triluminate, trisend, the difference was larger. In comparison with the drug trials, looking at health status that I looked at, the magnitude of difference is not as robust compared to the interventional trials. And I don't know if that's because the transcatheter therapies are more effective or patients are like sicker when we have to get to the point of intervening on them. But it's an interesting question, and you should look into this further. Regarding the association of NYHA and KCCQ with the clinical outcomes, I looked at in the same study actually. Both of them were associated with clinical outcomes at 1 or 4 years of follow-up, but it was more consistent in the KCCQ group.
How was the 6-minute walk in relation to this?
So the 6-minute walk was one of the items or measures used for validation of the KCCQ for functional capacity. And I don't have like a head-to-head comparison, but usually when there is improvement in KCCQ, there is also improvement in 6-minute walk test. I don't know like how they exactly correlate, but usually they go hand in hand.
Yeah, sir. One of the things that I don't think it was included in your list of placebo and Hawthorne and other. It's simply the art of medicine and what the clinician interaction with the patient can change how they feel. And the examples, I think, if we have patients self-referred to valve clinic because they had an echo elsewhere that said mild MR, and they show up and they're anxious and they think they're in heart failure, and you talk to them and you simply reassure them, and you see their face change, and they literally skip out of the clinic, and they feel better. And you've done nothing organic to them whatsoever. It's not a placebo. Then you have people, mostly it's interactions like that, but sometimes you have somebody comes in with a 5-meter AS jet who's asymptomatic, and you're like, are you sure you're okay? Are you sure you're okay? Really, no shortness of breath of any kind? Then they leave going, and they don't feel as good. But I mean, that's something that we do. A little microcosm of this is at the 30-day TAVR follow-ups, we've learned when we walk in and say, how are you? Generally, I feel a bit better. I'm getting a little more energy. They're kind of subdued in their improvement. But if we walk in and say, I just looked at your echo, your heart looks incredible. Your valve's amazing. There's no leak. You're squeezing hard. Everything looks amazing. I bet you feel great. And they're like, I feel amazing. But I mean, that's real, and that's the art of how we interact with patients. So how do you cleanse that from this sort of objective data?
Yeah, so great points, Dr. Little. So I would say that those examples that you provided now are more likely to bias some clinician-assessed outcomes like NYHA versus patient-reported outcomes, because if we look at the KCCQ, it doesn't have only symptom scale. Like maybe it will bias the symptom scale, but you still have physical limitation, social limitation, you have quality of life. So if you put all that together, this is why we see that KCCQ gives us like a better idea about like the overall condition of those patients and their overall health status. It would be in a perfect world, like if we go into the clinic encounter, we have a baseline KCCQ of those patients somehow in the future. I think that would be very helpful to guide how we should do
Well, it's funny, we've had this as a publicly reported outcomes conversation in the large programs. Do we give them the questionnaire after we've met them and told them about their great results?
It should be
Or do you make
before.
them it should be before.
And it should be also for serial follow-ups. Like I see this patient today, I'm going to see them again in 6 months. How does their KCCQ compare now versus later? Are they doing okay within in the interim, or they perform it poorly? Like, should I keep a closer eye on those patients because of the drop in their KCCQ? Should I change my medical therapies?
Standardized.
Yeah.
Yasseer, amazing presentation, as always. I am just going to echo the same thing regarding the cancer score. For example, when we assess a cancer score, it's thought that from 75 to 100 is excellent quality of life. 50 to 75 is good. From 25 to 50 is poor.
Fair,
and
fair or
poor to fair. And less than 25 is really bad. So there's a 25 points difference. And how can we just evaluate with just 10 points, and because there are 10,000 patients and the results are clinically significant? For example, if a patient, although when you mentioned and in your trials and the studies you mentioned, the points difference is up to 25 to 30%. But how would you translate a patient with a baseline quality score of 75 and it goes to 90? It's in the same class, good or excellent functional quality. Number one. The second point is regarding the sham control procedure. I think it has a lot of impact, which Dr. Zogby mentioned. And I have just one example for that renal denervation trials, initially when they started, the single-arm trials showed significant benefits. And then they evaluated with the control, which is a medication arm. There was still a significant benefit. But with arterial hypertension trials, there was no benefit, and now it's an area of great debate that with sham, the effect and significant effect went away. So what are your thoughts on these two things?
Yeah, thank you for the comments, Haitham. So like I stated earlier, if you have a baseline KCCQ of 70 or 75, you'll probably have less to gain from the intervention or the drug or whatever compared to someone who starts with a KCCQ of like 20 or 25. Those who start like with a 20 or 25, they can still be, let's say 25, and they gain like 15 points. They're still in the 25 to 50 range, but they definitely have like a moderate to large improvement in their KCCQ versus someone who had like started with 70 or 75 and they had only like 5-point improvement. So it's important also to know how to interpret the change in KCCQ and what does that clinically mean. Regarding your second point about the renal denervation and sham control, I don't think they looked at quality of life. You're talking about basically blood pressure measurement, right?
On the overall significant effect.
Yeah.
In terms
So,
of sham control.
I mean, again, like when you look at health status outcome as a primary endpoint, ideally it should be sham control, but you can still do open label trials if this is what you have, and you try to make the best out of the results and come up with meaningful conclusions.
Thank you. We are at time. Big round of applause for Dr. Sammour, Dr. Taha. Thank you both.